So I'm just going to get us started because we've got a relatively short space of time. So hello everybody, my name is Belinda Robertson and I'm Head of Improvement Support here at Healthcare Improvement Scotland. And my team are leading on the support for the implementation of the hospital at home services. So particularly in the Western Isles, you'll recognise my colleague Leanne, who's with us today and who's been providing you directly with the support. And we also have Sarah O'Shaughnessy on the call, who helps us with all of the logistics that are required and all of our communications and marketing around our support to hospital at home services. We're delighted to be joined, obviously, by Mr. Yousaf, the Cabinet Secretary, and especially yourself, Fiona. Fiona is a patient of the Hospital at Home service in NHS Western Isles and has very kindly agreed to share her story with us today. We also have various members of the Western Isles Hospital at Home team. So I will just very quickly ask each one to introduce themselves. Dave, could I start with you?
Yeah, so I'm Dave Rigby. I'm a GP. I help with sort of service development rather than the hard operational work that the others do.
Thank you very much indeed. And Gail?
Yes, I'm Gail. I'm hospital at home coordinator. Yes, got a small team, but a few of us.
And a very, very vital role that doesn't work without a coordinator. So a very important role in the team, Gail. Thank you very much. And then Fiona.
Hi, I'm Fiona Mackenzie. I'm the Nurse and Allied Health Professions Director and Chief Operating Officer NHS Western Isles, and I'm hoping that we will be continuing this service and spreading it to the Southern Isles in the future. Thanks.
That's brilliant. Thank you very much indeed. We've also got Maggie, who leads on comms for the Western Isles, and I'm sorry, Isla, I forgot to introduce you earlier. So Isla Bissett from Scottish Government, who's the policy team lead around the hospital at home service. So the purpose of today's call is really to have a bit of a discussion. Mr. Yousaf is specifically interested in hospital at home and has supported the development of hospital at home services over the duration of his tenure so far as Cabinet Secretary for Health and Social Care. So he has a specific interest in understanding a little bit more about how the service works, but also from your perspective, Fiona, on your experience of being part of the service. The Western Isles Hospital at Home service is unique and diverse, and it was initially set up as a response to COVID back in May 2020. It's expanded since then, obviously, to provide a wide range of services in Lewis and Harris, which allows safe and effective hospital-level care to be delivered at home, allowing, really importantly, family units to stay together and provide help and support to each other and their family members, but to allow anybody requiring that acute level care to be able to receive that in their own home, in their own surroundings, with the people who and the environment that they would normally live in and things that are familiar to them. So I think we're all clear about the absolute benefits of the hospital at home service. So I think I'll ask a question just to start us off, if I may, Fiona, and then I'll leave for Mr. Yousaf and others to come in to follow that up. So my first question, Fiona, is can you tell us how you became a hospital at home patient?
Yes, I was admitted to hospital in January with an infection. I was put into medical 2 and I was in a side ward. I wasn't allowed out of the side ward because of infection. So I then had to go off to Inverness to get an MRI scan done, and they discovered I had osteomyelitis in my foot. While I was in the hospital, they were giving me antibiotics 4 times a day, which was fine, and I was getting all my other tests and things done. But when they discovered I had the osteomyelitis, they decided to put me on to 4 antibiotics put into one, and I was only going to be getting it once a day. And then they made the decision that I should maybe get home, and the hospital at home team could get involved then. So I agreed to that too. And obviously, while I was in hospital and stuck in a side ward, it affected. I was starting to get quite down because with the visiting situation and that at the moment, it's not good not seeing anybody. So getting home, Laura came to see me the day I was getting home. She explained things to me, how things were going to work. And I got home the next day, and then the girls were coming in every day to me and explaining everything they were doing and getting my IV antibiotic, and they were doing my bloods and doing my blood pressure and all the things that I would have had done in the hospital. I was getting the same service at home.
Great. Do you mind, Belinda, if I came in, if you don't mind?
Yes,
thanks so much. Yeah, listen, thanks so much for chairing the call. Thanks to colleagues from NHS Western Isles and of course Healthcare Improvement Scotland. But most importantly, thanks, Fiona, for taking your time out to speak to me. It's you know, I can get all the briefings and I can get all the information and vital information from officials and colleagues that I want, but actually hearing from people who are using the service, as you can imagine, for me is absolutely invaluable. So it sounds like, Fiona, from your experience, has been a really positive one. What I'm really interested in with hospital at home, and I'll test this with some of the team that's here in a second, is how we bulk some of it up. Where's the room for expansion? And Fiona mentioned kind of geographical expansion, so that's important. But where also is the ability to expand it in terms of the services and the pathways that we care for? I wonder, Fiona, from your perspective, though, from a patient perspective, do you feel that your needs are met with the hospital at home service? Because what we're worried about is the perception that some people feel, well, hospital at home means a secondary service. And I don't believe it is, but some people feel a secondary service because I'm not in the hospital, and so on and so forth. So from your perspective, are your needs, your medical clinical needs, you feel they're met with this hospital at home pathway that you're on?
Oh, I certainly didn't feel at any time that it was a second class service. The service I got was first class, and the girls were excellent coming in too. And like I say, everything was explained to me, and I wouldn't have got any better in the hospital as I was getting at home, you know, any better treatment than I was getting at home too. The girls were all very good.
Good, excellent. How long have you been, did you say, on that hospital at home?
I was 6 weeks. I've actually finished, there's 2 weeks since I finished, but I was 6 weeks getting the IV antibiotic to every day.
Great, every single day. So and there was never any issues or problems in terms of that daily.
No, they were coming in the same time every day, unless they were held up with anything. They were coming in every day between 12 and 12:30. So I knew when they were coming in, you know, to just could plan my day around about that as well too. Yeah,
and again, it just I suppose this would be true in any setting, but particularly I suppose in island setting, it's so much better, I assume, for you in terms of not having to travel. That would have been a real difficult one. And then obviously, as you said, visiting being pretty constrained during the pandemic. So for your actual, not just your physical health, but for your mental health.
Well, my mental health. Because while I was in the hospital, as you know, time was going on, I could feel myself going down. And the nurses used to say to me, they used to see a difference in me because they thought I was stuck in one room, you know, all the time. I wasn't allowed out. So coming home, I've got friends, family, you know, you're in a more relaxed environment too. And it's certainly much better for you to, you know, it does help you. And I think it helps you get better quicker as well.
Yeah, and it sounds like you built up a bit of a rapport and relationship with the girls that were coming
in.
in.
The girls are great. The girls are really good too. You know, just every one of them, you know, that come into. I had 5 different ones coming in to me, and every one of them, you know, it was great. And it was more relaxed, and we could, while they were doing my IV, we could just sit and, you know, talk, and it wasn't rushed. You know, just everything was just kind of chilled out.
Yeah.
Rather than in the hospital, everything was just so busy. You know, the girls just didn't have time.
Yeah, that's really interesting. Actually, that's a really important point, isn't it? Because you're right.
Yeah.
I mean, our hospitals are going to be under pressure for quite a period to come, I'm afraid, and therefore actually getting the time with patients. When I speak to doctors and nurses, they tell me at the moment they just don't get the quality time that they would like to have with a patient. So actually having that in your home, through hospital homes, pretty invaluable.
And I suppose that some people, if you've got hospital at home, the nurse could be the only person that you see in the day. So it's nice for them to be able to sit and have a chat with you, you know, to just to keep your spirits up.
Yeah, for sure. And in terms of your follow-up, and you can go into as little or as much detail as you want in this. Is there much in terms of the way of follow-up for you? And again, are those follow-up needs being taken care of for you as well?
Well, yes, I haven't really had any follow-ups. Nobody's been in touch with me, but I know I did have an appointment with the orthopaedic surgeon, and that's been done and that's been sorted. He doesn't want to see me anymore, so they're quite happy with the way things are at the moment, just to keep an eye on things, you know, and if anything starts deteriorating, I just have to get back in touch with them.
Good. So you find the whole experience a positive one, but also
it's an excellent service. It really is an excellent service. To highly recommend it to anybody, you know, that's got the choice of being in hospital or having this hospital at home. The hospital at home is the way to go.
Great. We should probably make you an ambassador for our hospital at home program.
And thankfully, we're recording this, Mr. Yousaf, so we've got that line to use.
But you know, I've met with a number of hospital at home kind of users and patients over my time, and I've not heard anybody, touches wood here, have a negative experience. It's all been a really positive experience from those that use it. So I'm really pleased, and thanks again, Fiona, for making the time. I really appreciate it. I don't know, Belinda, I was quite keen to test some of the other issues with some of those online.
Yeah, absolutely. And yeah, Fiona, as Mr. Yousaf said, thank you so much for sharing. And please do stay with the conversation. And if there's at any point, if there's anything that you remember that you haven't had the chance to say yet, then please do just do let us know, and we'll bring you back in. I think if we move a little bit to the service now, because I think it's useful, as you said, there are many things that you want to find out about that. I wondered whether it would be good just to start off with something slightly more generic, with maybe yourself, Dave, and Gail, if there's anything that you want to come in on. But just thinking about the main challenges in developing and evolving the service through COVID, because I know it wasn't as easy as we'll have a service and we'll start it tomorrow. So,
do you want me to come in, Gail?
Yeah.
So I guess, you know, it was a brand new service in May 2020, so there was no knowledge, I guess, and no experience among staff. So obviously we are treating hospital level patients in the community. So I think that was one of the biggest things, getting that buy-in from our clinicians to say that this is not only effective, but it's also safe and well governed, and that we are able to deliver exactly the same standard of hospital level care in the community. As you can probably imagine, the other big challenge in the Western Isles is the geography. So although we've got an island chain with 3 separate island groups, for most of the service at the moment, we've started with Lewis and Harris, so we're covering 4/5 of the population just now. There are some areas we've taken on things like assessment of people who need COVID drugs, the COVID positive patients, and we're doing that across the whole patch. So we're already testing the waters of providing a Western Isles service in its entirety, and we're going to be developing that into making sure that everybody in the Western Isles has the access to the same level of care that Fiona's had throughout the service. So that's all to come in the next few months. But yeah, I think winning hearts and minds is obviously a big thing when you're setting up any new service. We're a small team, but we flex. I'm saying I'm not part of the operational team. Laura, who's sitting next to Fiona, and Gail are kind of they're it really. There are another couple of nurses if Laura's off, but that's the entire team. That's the team that, you know, one coordinator, administrator, and one nurse providing care 7 days a week. And we work really closely with colleagues in the hospital out of hours, but we make sure that patients are selected so that, you know, there aren't many calls on the out of hours service. So, you know, people who are extremely unstable, we wouldn't bring into the service, you know, for safety reasons. But a really small team. But I think it just shows what can be done. Between them, the girls are saving 100 to 120 bed days a month, which I know in the grand scheme of things may not sound a lot, but for a population of 20,000, it's been a huge help during COVID pressures in the hospital. And we know as we develop that we can expand that. There's potential and there is a demand to see that expanding. So we're currently a 6-bedded ward. We'll probably move to a 9 or 12-bedded ward when we take in the Southern Isles. And the other great thing is we very much like to use technology when we can. So it will be one virtual ward over the 3 island chains. We already use Near Me for patient consultations if needed. So yeah, lots of exciting things to come, but you know, it takes time, I guess. But I think the girls have done amazing in just 2 years to get to where we're at.
Thank you. Gail, did you want to come in to add to anything to that before I just probe some of what you guys have said?
Yeah, no, I think Dave's kind of summed it up. I think it's just been setting up and just keeping a wide patient cohort and just addressing each patient that when the team comes to us and says, can you do anything for them? Kind of just, it's been exciting, kind of just trying to figure out how can we do it. It's not a no or a yes straight away. It's kind of like, how can we make this work for the patient? What's the best thing we can do? What can we offer kind of safely? And it's changing all the time, but it's just, it's been good. Distance is a challenge, getting the nurses out. You know, some patients are maybe an hour and a half drive away, and that's a big chunk of the day. So a lot of planning and things, but yeah.
Yeah, no, I know that particular dynamic becomes even more acute when you're considering expansion into the Southern Islands, and it's the right thing to do, of course. I think you're right to start. Obviously, we're 4/5 of the population, as David had mentioned. We're 4/5 of the population. That makes perfect sense. But my goodness, my colleagues Alistair Allen and Angus Brendan McNeil wouldn't forgive me if we didn't agree to expansion to the Southern Islands, particularly Barra and Battersea, where Mr. McNeil is. But I do think for me the geographical expansion is certainly one element of it. What I'm really interested in is effectively your from what you've said, both David and Gail, there's not really a patient that you look to exclude. Now there's limitations, and as you said, Gail, you'll look to see how you can do it, and if it can be done, it can be done. If it can't, then absolutely fair enough, and that'll be a clinical decision that'll be taken. I suppose the question is, from a more kind of strategic perspective, if we want to increase those virtual bed days, which I have to say the number you've quoted, 120, is impressive, given the population that you're looking after. And frankly, every single gain, marginal as it may sound, is going to help us in this coming period, let alone into the future. A more strategic view of how we might expand the service in terms of the various different clinical pathways. I suppose by that, what I mean by that is, well, you know, looking at this and the hospital at home program you've got, and saying actually our goal would be to be able to offer XYZ service and treatment at home. But in order to do that, what we would need is this equipment, this staffing, and this level of investment and resource. And is that something you're working on to then present to the health board? And no doubt the health board come to me and say, you know, actually, you know, if we could really expand this in the next coming phase, however many months or even years that might take. We've got the drive to do this because, as Belinda had said in her opening, I'm very enthusiastic in my support of hospital at home, partly out of necessity. I think we've got to do this, but also as Fiona so eloquently described, I think as a win-win for everybody involved. There's a win for the health service, but clearly a win, most importantly, for the individual that we're treating, in terms of being treated at home in their own space. And all the physical and mental health benefits that produces. I see Fiona's got her hand up, so happy to go, Fiona, and then obviously others that want to come in, just raise your hand, please, and contribute.
Thank you. Fortuitously, we had a meeting this morning, a catch up about it. One of the key things for me, apart from the fact that it is very beneficial and person-centred, is the fact that this will really support our COVID recovery. As we're working on the annual operational plan and looking at how we can attack our tackle our waiting lists. One of the things that obviously in the Western Isles, our waiting list is nowhere near what it is in the mainland. But for us, it's not good because we were pre-COVID 100% TTG, and we want to get back to that because it's good for patients, it's good for the system, etc. And one of the things that we know we can't always access mainland facilities. So if we can do as much as we can on island to prevent patients from having to travel, then we can do that. But in order to do that, we still have to maintain our acute facilities in the community, as it were. And that's where we're looking at expansion. We're looking at, if this is an extension of a ward, so a secondary care acute ward at home, then we need to have allied health professions going in as well and looking at how some of the preventative stuff in order to, you know, treat people at home. So we're looking at different pathways. We've had some discussions this morning. Because we can as a system, we're very fortunate here in the Western Isles, we can look at the system as a whole. So it's a Western Isles resource. It's not about the hospital, it's not about community, it's not about primary care, secondary care, it's a Western Isles resource. So we're looking at unscheduled care, we're looking at how can we, even at the front door, look at somebody and say, well, actually, they need acute services, but we don't need to be in an acute inpatient bed. So turning people around at that point, rather than getting them into the system and then having to get them out. So I think for us, we've got a lot of work to do. It's actually very exciting because we're able to then achieve what we want to achieve with trying to cancel out that debt and the COVID and making sure we recover, but also ensuring that we take care of our patients at that point of need. So there's a lot of work ongoing just now. We're looking at how we can turn them at the front door already. So yeah, we are certainly, and we're looking at costs, and we're looking at how, you know, how do we balance that against the saving of bed days and the costs, etc. Sometimes we have to invest to save, and we know we will save eventually.
And Fiona, as part of that work, I know Leanne and the team have been working with yourselves and all of the hospital at home teams to look at what you know, a kind of high level figure for an expansion of the service would look like. So you have done some of those calculations already, and we can, Mr. Yousaf, we can provide you with some information, you know, kind of off the call if that's helpful. Just a little bit more detail about the sort of skill mix, etc., that would be required. Dave, do you want to come in?
Yeah, it was just to say, I guess that we, you know, I guess in answer to the question, we've done a lot of work with Leanne and the team about where we think we can take this, because I think, you know, as far as we're concerned, we're probably just really scratching the surface. We're very much, as Fiona was mentioning, facilitated discharge, so getting people home who've been admitted to hospital. We really want to move to turning people around when they present at A&E, and then get direct GP referrals under hospital at home, so not under GP care, but under a named consultant. And we know, I think the things we know to do that and make it effective is we do need a little bit of operational medical input, which is the case, I think, in all services on the mainland. At the moment, we're really a nurse-led service, which I think is just a testament to how well nurse-led services can happen, because we don't have any medical input into the service itself. Everyone's under a medical consultant, but all the delivery of the services through nursing and coordinator support. So in our bid, we're looking at maybe a bit of medical input, which I think that's the thing that will probably let the GP direct referrals happen, because the hospital consultants will feel better supported in that way. A bit of pharmacy input, which will really help with turning people around quickly from A&E. And I think the other thing about the service is because we're a small island, we flex as much as possible. So yes, we're hospital at home, but we've taken on lots of other strands. We've been the coordination for COVID monitoring equipment, as I was saying earlier, coordination for the assessment for COVID drugs. We've just taken on things like intravenous treatment for patients with hip fracture to get them out quicker from hospital and ensure that they don't miss out on their osteoporosis treatment. People with low risk heart attacks who are waiting to go to Glasgow, there's plans to take those on as well, so that we can monitor them at home, so they're not stuck in hospital. while they await, because obviously the pressures in Glasgow are huge and patients can wait a number of days. And we've started to do some work with the interface programme around outreach respiratory work, so that we can stop people with COPD and similar conditions coming in. So I think we're brimming with ideas. We obviously will, there's a cost, as Fiona mentioned to that, which is that what we're working with Leanne and the team about as well.
I think it's really important, Dave, thank you for that. It's really important to say that the cost is twofold, because obviously we need, Laura's just off camera because she's fundamental. I don't know if you're brave enough to put your head around Laura and just have a moment in the spotlight. But Laura is obviously fundamental to the delivery of the service, and we've been looking at some demand capacity and activity work with teams. But equally important are things like handheld scanners and other bits of equipment, which mean that if a patient is an hour and a half apart, then potentially as the service expands, it might need more equipment to enable, two people to see different patients, for similar things, and not have to wait for equipment to come back into a central point, or, so really important that the investment is understood to be equipment as well as people in these initial phases, definitely.
Yeah, agreed. And look, I'm really pleased about what I'm hearing from colleagues on the line, because there's, as David just said, you're brimming with ideas. That's what we want. Clearly, there'll be a financial cost there, and that's for me to worry about, as opposed to people on the call necessarily, because I think Fiona's point was absolutely right, that spend to save is where we're going to have to go with this. But I think we get a really significant bang for our buck, a really good return actually for every pound that we're spending in hospital at home. And again, this is vital to have done actually at any point in time, even more so given the current pressures that we're absolutely under. So I think I suppose my encouragement would be to be as ambitious as you possibly can. And I know you've done some of that scoping work already, Belinda and team at HIS. So an initial off-table draft of that would be helpful. But certainly, we've got a way to go in terms of those health boards that haven't got our hospital at home programme underway. For those that do, really, again, the encouragement being to be as ambitious as they can in terms of pathways. And I was talking to one health board who were looking at, for example, what they can do around chemotherapy potentially at home and cancer treatment at home as well, which I was really pleased to hear. And the use of technology, of course, has just boomed since the pandemic, and I think we just don't want to lose that. So I suppose my message is, I can't promise you a blank check, and you wouldn't expect that, but as nice as it might be, but you clearly, what I need from those on the call, but also I say this to every health board, is be ambitious in your scope. What you think you can achieve, be ambitious in your timescales, and let's work out what we can do within the financial constraints we're under. But this is really positive to hear how ambitious you already are.
Well, thank you very much indeed for that encouragement. I can assure you that we've worked with every single team and encouraged them to be as ambitious as they possibly can be, in order that we're able to deliver the most effective and wide-ranging services across Scotland to meet patients' needs in the longer term. And shown us just such a great example of how important it is to be able to stay at home and actually to be able to see your loved ones every day. And for people who have, community care packages and things like that, that you don't lose them because you've not, you've been able to stay at home and haven't been admitted. So all of the support that wraps around, patients of different levels of acuity is fundamentally delivered and supported by a hospital at home service. So thank you very much for your encouragement today, Mr. Yousaf. We do have all of that detail available, so it will be winging its way over to you very, very shortly. Could I again thank Shona very much indeed for being prepared to share your story with us. We really greatly appreciate that, Shona, and it just helps us all understand the importance of the hospital at home work. And thank you to the team from the Western Isles for making themselves available and sharing some of their information with us today. It's amazing how quickly half an hour goes, and we're now a minute over time, so my apologies for that. But I hope everybody has a good rest of Monday, and thank you very much indeed for your time today.
Thanks, everyone. Thanks.
Thank you.
Take care. Hopefully see you soon in person. Take care, folks.
Yes, thank you.
Bye.
Thanks. Thank you. Bye-bye.
Bye. Bye.